25th of this year,
It was okay to take a break.
on August 25th of this year, just a couple of days ago, the Journal of the American Medical Association's Internal Medicine Division released a study called Medical Cannabis Laws and Opioid Analgesic Overdose Mortality in the United States from 1999 to 2010. And basically what this means is that they measured the death rate of opioid chemicals, which include heroin and prescription medication, in states that enacted medical cannabis laws and compared them to other states that did not have medical cannabis laws. And they determined that medical cannabis laws are associated with significantly lower state-level opioid overdose mortality rates. However, it called for further investigation. As a result of that scientific evaluation, a press release was created called Lower Opioid Overdose Death Rates Associated with State Medical Marijuana Laws, and one of the commentators on that was Marie J. Hayes, who's a PhD from the University of Maine in Orono.
And in fact, we have her on the line in the queue, and welcome to Planet Green Trees.
Okay, thank you very much.
And we understand you're calling from the East Coast, where is it, right, Maine?
In Maine.
Maine, fantastic.
Yeah, I'm calling from north central Maine, where the University of Maine is, in the Bangor region, Bangor, Maine.
Nice.
And I know, Jamie, who had set up the call, I know that you don't take an opinion one way or the other on this. You are neutral, a scientist studying this, and the interest that we all have is that, there's as many of us in our community. I'm a lawyer. There's lawyers here. There's caregivers and activists about medical cannabis, and we've heard it anecdotally. Doctors will show more than anecdotally, the reduction in the maps, of people taking opiates, but that that cannabis does in fact is a viable way to treat chronic pain and pain. All right. With that being said, your study, one that you're involved in, concluded that, or at least statistically found, is that right? That's the proper way. Statistically found that there was 25% reduction in overdoses of opiates in those states that had medical marijuana. Is that a fair way to say it?
I think the study is the one I'm commenting on.
Right.
The author is Marcus Bachuba. He is the main researcher. I am commenting and reviewing the article that he did for JAMA, and JAMA is the Journal of the American Medical Association, and I wrote a commentary. So just to summarize his work and his team from the University of Pennsylvania, the fundamental finding was that using CDC data, looking at two groups. One group is states that have passed medical marijuana laws since 1999, any time in that window to, I think, 2011. And the variable that they were comparing was opioid mortality deaths over that same time period. Again, comparing states that had passed medical marijuana laws versus states that had not. And I think from reading the article, you might remember that the number was far fewer. I think it's 13 states were included in that time period. And so when they looked at that analysis, they found that the states that had passed medical marijuana laws actually had higher rates of opioid mortality than states that had not. So at the first pass, it looks like there may be perhaps more risky opioid drug taking in states that had passed medical marijuana laws. However, in the secondary analysis, the authors looked at the variable that they termed implementation, and by that is meant once laws have passed, how many years since passage of the laws has it been, and has there been any change in opioid mortality since passage of the law, and in some cases they had as much as 10 or 11 years out. And what was found statistically, making corrections for differences in the number of years that had passed since the decision to have a medical marijuana law, they found that there was a dramatic and significant decline in opioid mortality deaths. And these are accidental. They're non-suicidal. The idea is that some sort of error has occurred, and people that were taking opioids for chronic pain or taking opioids illicitly had overdosed accidentally. In states that had medical marijuana implementation, there was an improvement, or rather protective effect. That protective effect of medical marijuana improved with time, suggesting that once dispensaries and systems for delivering to patients the medical marijuana had become more sophisticated, there was a linear trend in decline of deaths. So that's a striking result, suggesting that these two variables may be related. It is not a proven finding, it's a correlation. So, again, increases in the number of years since medical marijuana laws were passed was associated with statistically significant declines of rather clinically significant magnitude on rates of opioid mortality death.
Let me ask you this, and I see that in the article, and I think these are your comments on the study, and where you're identifying what could be a trend, and the researchers really fell short of attributing it to a lack of overdose, and there may be a relation. There's a lot of not certainty, scientific certainty, but statistically there seems to be a correlation, and I think that's the way that you phrased it, as factually. But my question would be, has any other type of, I don't know if there's other comparisons that have been made, but what other reason would it be? I'm just curious. Like, have you? Is it to be said that there's been an increase?
Yes, I understand your question. So some of the other things that it could be would be like other policies to stem the rise in opioid mortality, and those other policies are things that decrease diversion, and so they would be things like prescription monitoring plans, which your listeners may know means actually keeping a record at the pharmacist of the person's name and address, the doctor's name and address, and getting some kind of match in the computer if a person seems to be doctor shopping and asking for opiates after another doctor has stopped them. That would be an example of a person trying to treat a dependency on opioids by going from doctor to doctor to get pain meds. That policy doesn't seem to work very well, although I read in the press that somebody in the Florida system had suggested that they had gotten some positive results with that method. But actually, Paluzzi and cited in my commentary had done work like that and shown that there appears to be a weak effect to no effect of prescription monitoring plans and also oversight of pain clinics. These are the kinds of things that sound like great ideas, because that seems to be what's wrong. There's too much prescribing, there's too much diversion, there's too much concern about individuals who may be getting more drug and then again diverting it or selling it to others. Those methods to control that illegitimate use of opioid medications, which is thought to be one of the ways in which states respond to freely available and quite dangerous medications like Percocet and OxyContin and Vicodin. Those medications are, in combination with other polypharmacy. So, for example, even psychotropic medications that may be prescribed, alcohol, benzodiazepines. Those polypharmacy combinations with the opioids that may be procured legally or illegally. And in Marcus Bachup's study, he had both kinds of persons in his study, and about 60% of them had prescriptions for the opioids at the time of death, but another 40% did not. So it suggests that they had become potentially dependent, but certainly heavy users. And so the problem is very important to ask, what are we doing that seems to be improving this runaway rate of opioid mortality having to do with these heavy medications? And so this correlation with implementation of marijuana laws and looking at it in a time series, so over time.
How many years from the time that sophisticated?
So they vary. So of the states that they studied, some of them had only implemented their law a few years because they were passed in 2010 or 2011. Others,
right.
Instead of taking the broad range of all these years, they did it individually. Like Michigan was 2008 to 2000.
The question is, can you look at the data and say that how many years did it take for the development of a sophisticated
implementation, as she's describing?
Oh, that's a really good question.
How long does it take for this rate?
Actually, there's a decline in each individual year. In year one, the average reported a 19.9% decline, all the way up to year 6, which reported a 33.3% decline in deaths from those sourced medical situations.
Once they take the guns out.
So the increasing, as you mentioned previously, Dr. Hayes, that increasing improvement in that mortality rate over time, and you also mentioned that there's a slowly eliminating all the other potential factors that could have had a mitigating circumstance in these numbers. And it is just a statistical survey as opposed to a human study. So,
Rick, I think what you were pointing out was, Dr. Tell me if this is really the point that he was making, is that the longer the medical marijuana state law is in effect, you're going to see numbers decreasing. That's essentially what that statistic...
That's the whole point of the study. So one of the questions that I think you guys were starting to ask, which was, or at least I thought you were going there, how about individual states? Let's say one state has a few years, another state has 11 years. And could we look at them individually? And the answer is no, because there's already a very small sample size. Remember, the number of people who die of opioid mortality is related to the population, but relatively low numbers in these CDC reports. Similarly, the number of states that have passed medical marijuana laws is quite low. So you can't look at individual states with all these low numbers because statistically it wouldn't have the power. So the statistical power would be diluted, and any of the conclusions would be much more tentative than by pooling the data in the way that they did.
So we really couldn't add any of the new medical marijuana states in there and then re-up the study because it would dilute the available data.
Yeah, because it's really hard statistically to model this. And the clever part of the study is they're essentially creating this implementation factor, which is really time since passage of the law. That was creative. That was a good idea because just passing the law isn't enough. We need to see, and as you know, the legislatures are all different in the way they pass the law, what they pass it for, how rapidly they get the dispensaries going, whether or not the federal government gets upset about that and responds and slows them down by closing dispensaries as they did in California. So there's so many differences state to state to state that this solution is really a social science variable, this implementation variable, and it takes with it a lot of assumptions because we don't know how a particular state is going to solve this problem.
Well, your data indicates in year 5 there's a 33.7% decline in deaths. We're in year 5 of the Michigan medical marijuana program. Although your study stopped in 2010, it's very reasonable to assume that our state would be just like all the rest of them, and on average would be somewhere about a 33.7% decline here in year 5. Would that be assumed?
That's a big assumption. That's a very you really can't say that. What you could say is that if and I believe Michigan is included in the Bachuber study.
Yes.
So take a look. I think you are. He may be able to give you from his database, which is again public and CDC based. So as a citizen, I believe you would have access to that information. If you wrote to Dr. Bachuber, you probably could ask that question. You observed an average of 33% by the fifth and sixth year. What exactly did Michigan do? And I'm sure he could give you a very good answer to that. And I suppose there may be a table in that paper. I think there is not, but you may go back and look at the paper.
Statistically, is it common that a population or a state would have a similar percentage of citizens that we're treating with opiates, or that are diagnosed with chronic pain, or like for example, Michigan has a post on their website: 25% of people sought treatment for chronic pain, which is about 2.5 million people. We have 10 million people. Is it that a similar statistic, or but Michigan, of course, is a
the finding that Bachuber had was that the states that had medical marijuana laws were statistically more likely to have higher rates of opioid deaths than the states without medical marijuana laws. So that tells us something important. It may either be that the states themselves have more of a problem with illicit drug use, or that the states themselves have some other factor that's leading to rates that are on average higher than states without. Certainly it would suggest to me that states with medical marijuana may actually be states who have more of a burden of opioid mortality and probably therefore more of a burden of drug taking amongst, and by that I mean illicit or taking off prescribed levels opioid medications. So opioid mortality deaths, again, I can't, it's very complicated. They're not generally opioids alone. They are usually in combination with another drug. And
not marijuana.
Another substance. The other substance could be
usually not marijuana.
Alcohol, benzodiazepines. Marijuana does not stand out as pushing subjects to, or patients or the deceased to a mortality. There seems to be that the drugs of interest amongst the researchers right now are the combinations of opioids and benzodiazepines, which, as you know, have respiratory depressant effects, as does alcohol. And that's that respiratory depression effect, which is the main effect of high doses of opioids. But if you combine that with another drug that has a similar effect, you get the Marilyn Monroe respiratory depression of barbiturates plus alcohol, right? So there are drugs that have these respiratory effects that are probably going to be much more risky for people on chronic pain medication. I know of a case in Maine in which the man was in his 70s. He was a upstanding uncle of the family. Everyone was very much keeping an eye on him. He had chronic pain, but he was a drinker. And when he received his opioid medication, he was happy because his back pain was getting better, and he was found dead due to an apparent opioid accidental death. And I think most of the coroner reports in this kind of case would say it is that polypharmacy, the opioids plus the alcohol, which he probably wasn't carefully enough counseled about. So the opioid mortality deaths are complicated, and they generally are not simply the case where the person has taken too much opioid. They usually include another drug. And I think there's a person, Marcy Swart at the University of Maine, who's done a lot of forensic work on opioid mortalities in Maine, and she would be a great person for you guys to talk to.
Let me just say one final thing. It's no matter how you're analyzing it, even if it's based upon a community that has a higher use of drugs and they're just using marijuana instead, which is reducing, which I think is the possible one of the interpretations. Either way, like the presence of marijuana in these states, any way you cut it is not hurting. In other words, like there seems to be some benefit. At the very worst, one could draw
that
conclusion. That's what it looks like. And my question is, who? I'm curious. I have no idea. It's like this is such a untraditional, end result. I mean, just like the study-wise, like an actual desire to prove that. I mean, it's obviously scientific, and it goes towards the concept of safety and these mixture of drugs that are causing all these deaths. I mean, is that what it was? Like it was almost like the Hollywood. I'm just curious, like who is behind the concern of or like the research. Who funded it? I'm just curious, or where did it come from? Like, what, cause it's kind of like a.
This study was a National Institute of Health funded study, according to the disclosure. National Institute of Health and the Center for AIDS Research at the Albert Einstein College of Medicine and the Montefiore Medical Center is what's listed as the.
I think that's critical because we are beginning to see some of our research questions that involve marijuana being included in National Institutes of Health funding. So this is an example. Mining CDC data on drug use or drug overdose, that's a really that's a new thing. I think the NIH has been less active in pursuing marijuana research, and I think what's gone on here is probably the initial questions were not necessarily that marijuana was necessarily playing a critical role in opioid mortality. I think they discovered that from studying what states were doing. So I think the idea probably came out of a lot of work that was maybe going in a slightly different direction and then made this discovery. That would be my guess. But, again, you probably should speak to Dr. Bachuga about that.
Now, in the commentary written by yourself and Dr. Brown, you wrote, the potential protective role of medical marijuana in opioid analgesic-associated mortality and its implication for public policy is a fruitful area for future work. Could you expand on what you meant by the implication for public policy? What we're looking at here is obviously it's more difficult for the National Institutes of Health to control a study that doesn't involve the distribution of marijuana, which has been one of their key methods of restricting information as far as human trials go. So you mentioned that this new science of data mining the CDC library. Is that what you're referring to with the public policy?
Yes. Well, no. Actually, I think we always look at a study a human study with the possibility of clinical implications. So in this case, it suggests that there could be a benefit to medical marijuana legalization for the very small population of people that overdose on opioids, that we could potentially protect people that are treating themselves with opioids either for chronic pain or for other reasons, such as stress reduction, psychiatric disease, or any aspects of addiction. That in both cases, the use of opioids are associated with mortality risk that is very significant. And so the public policy question here is, if individuals that are using a pain medicine either for chronic physical pain or for what I was writing about, which is psychological distress or psychological pain, that opioids also decrease the stress response. They also have a rewarding aspect, as all drugs of abuse do, and those are attractive to individuals that have significant psychiatric distress. So both categories of patients may take opioids and may take them or misuse them. And if medical marijuana availability creates another avenue, either in and of itself as a treatment for chronic pain or psychic pain, or actually
as a substitute for alcohol.
As a substitute, or as I was thinking actually as an adjuvant. So as an adjuvant, the idea would be it would have an additive effect on a relatively modest dose of opioids, right? So the person is taking a modest dose of opioids, has cancer pain, says, oh my goodness, this isn't working, I think I have to take more of that med, and instead has an adjuvant available such as medical marijuana, the person will not take the additional opioid.
Yes.
And so they may be protected.
What a great opportunity.
It sounds so unschedule one to me.
It sounds like we've discovered medical benefits of marijuana, and that redefines this off of Schedule 1. You just have to convince the DEA, the Food and Drug Administration, Eric Holder, and Obama
all that
to do
federal research that seems to be going on about it just seems so on Schedule 1. I say that it was, with love and sarcasm.
And I'm sure that schedule makes it more difficult for you to do any certain types of surveys and scientific studies, doesn't it, Doctor?
Well, it doesn't make it easy to do clinical trials. So clinical trials are the gold standard, right? And so Dr. Abrams has been doing clinical trials looking at synthetic cannabinoid, dronabinol, as an adjuvant for treatment of pain in patients currently taking opioids, and has found in several studies some very promising results. So I think probably a lot of the public policy confusion is how the drug is administered, because I think people are okay with another pharmaceutical, and they are actually not so okay if the drug is delivered in a way that may carry risks in and of itself, such as smoke. So smoke in itself, is not considered a healthy behavior, and I think public health advocates and public policy people find that to be a very significant barrier.
Properly admonished.
What about Donald Taskin? I thought he was just talking about that earlier.
I have to suggest that in those states that we surveyed, there that the predominant method of use of marijuana is smoking in every one of those states that were included in the survey from 1999 to 2010.
All right, that's probably enough. We think we could go. You've been handling all of our, fielding all of our questions. That's
doing great. Yep.
That's another. We can take up the smoking thing. Listen, any final thoughts? I didn't want to keep you, and I really appreciate you putting up with us.
Well, I think that since your show seems to be about looking at advocacy avenues. What's the way that things could be promoted? Certainly, science like this is a good basis, and I think there are promising results also in the clinical trials where vaporized cannabis has been used instead of a pharmaceutical like dronabinol. So there are other approaches that could be more convincing to the general public, but I don't think in this environment of anti-smoking, since we've all learned our lesson with tobacco, I think we're worried now about industrial exposures, diesel fuel, solvents, work-related exposures to the lung. Lung cancer is the second cause of adult deaths. So I think you have to get around that. That's the big issue is drug delivery. And so I think certainly the safety and the efficacy of marijuana seems to be making strides in getting across to people. But I think not the delivery. People are still quite unhappy about that.
And the personal vaporizer industry is taking off like wildfire. So the vaporization is a very real opportunity for most cannabis smokers nowadays that live in urban areas, and it will be within a few years for all cannabis smokers across the United States as that technology spreads.
Probably. And then we have to ask what that technology has for risks. So there's a lot of work to be done related to safety, and I think that would be a really important problem to tackle.
Absolutely. Guns own safety.
Yeah.
Well, listen, thank you so much for joining us tonight. I'm going to put you on our list of fans of Planet Green Trees. Just kidding. Really appreciate you putting on that fascinating study, and we hope to talk to you the next time around where it's overwhelming, convincing, and scientific in your conclusions. How's that?
Okay, thank you, and it's very nice to meet you.
Call
All right,
back.
have
Call
a great
back.
night.
Thank you.
Thank you.
What a great interview.
Bye-bye.
Bye.
Bye.